Good afternoon, everyone. I was waiting for more people, but I think I'll make a start now. We only have the hour, so thank you all for coming. So this is part of our Expert Insight series. Obviously, we're here to talk about reactor isotopes today and various other isotopes. This is part of a wider series, so if you would like to know anything else about upcoming events, we'll let you know. But the idea of this talk is to give you an idea of a particular topic of interest to the nuclear community in the context of the Dalton Institute. So just a few housekeeping things before I start very quickly. So no planned fire alarms, fire exits at the back and the front if we do need to leave in an emergency. And I believe toilets are by the stairwells, so if anyone needs to go, please feel free. We also have some water at the front. I went and bought loads of water, so if you are thirsty, just come and ask one, it's fine. So I'm Jake. I'm, again, a Dalton champion. I'm also doing a PhD. I'm in my third year now, so I personally research decontamination, decommissioning scenarios, whereas I appreciate that's not what it talks about, but that's my background. So I'll introduce our speakers. So we have Thomas Day Goodacre, who's a nuclear physicist specializing in the development and application of irradiation stations, targets, and ion sources for the production and study of radioisotopes. He has over a decade of experience in the field, including operations at CERN and Triumph, which is, I believe, a cyclotron in Canada. He rejoined the University of Manchester in 2023 as a Dame Kathleen O'Loughlin-Shaw Fellow and UKRI Futures Leader Fellow. His current research encompasses both fundamental physics and novel medical isotope generation. And we also have today Tom Hayward from Astral Systems. He has over a decade of experience in the nuclear medicine field, from isotope production through to development of FDA-approved radiopharmaceutical drugs. Tom currently leads Astral's stakeholder engagement in the nuclear medical industry program, while also leading the development of the medical isotopes. He has held positions in the UK and the US in top-ranking academic institutions and world-leading industries. But yeah, I think that will do for now. And then I can ask you two more about your backgrounds more specifically as we go through the talk. So the format is an in-conversation thing. So I'll sit here, I'll ask them questions. It's a very fluid dialogue. And then towards the end of the talk, we'll have more of a Q&A. So we'll involve the audience. So should we start very simply? Why are we interested in radioisotopes for medicine?
Okay, hopefully you can hear me okay. So there's sort of lots of ways to categorize it, I suppose, but you can think about it in terms of either diagnostics or therapy. So a significant fraction of the radioisotopes that are used currently in hospitals in the UK are related to diagnostics. So this would be SPECT or PET scans. This is what people are very familiar with. And then increasingly therapy is becoming something that is of interest. And I think we're going to maybe talk a bit more about how either some isotopes could be used for both, or how partner isotopes can be used for first diagnostics and then therapy. But yes, it's sort of two types of applications. It can be both identifying the ailment and then hopefully curing it.
Yeah, thank you. I think just to add to that as well, there's three main types of radioactive decay: gamma, beta, and alpha, and all of those can be used in nuclear medicine in different scenarios, like you said, either diagnostic or therapeutic. So there's a wide range of isotopes that we're interested in and have value in nuclear medicine.
Thank you. Okay, so the next question might be, why are there so many isotopes? Why not just use 2 or 3? Why make it so complicated?
Yeah, so good question. So typically, it's obviously different isotopes have different half-lives, so it's important to match the half-life of the isotope to the indication that you're either looking to diagnose or looking to treat. So you don't want to inject someone with an isotope with a 4-year half-life, because it'll take a long time to clear potentially. Equally, you don't want to use an isotope with too short a half-life, because it makes it very difficult to produce, process, purify, incorporate into a drug molecule and administer to the patient. So there's a kind of Goldilocks zone of isotopes. But then there's also the energy of the isotopes as well. So beta emitters, for example, have different energies, which can result in different amounts of damage to the tumor. There's a lot of different factors, and there's not really one isotope that suits every situation. Different situations require different properties, basically.
Brilliant. And one for Thomas of Manchester. Because I mean, for example, actinium-225, I'm currently read about. It's an alpha emitter. It's in a lot of our professional contexts, we're actually trying to avoid having these anywhere near people. So the idea of injecting them into someone's body as part of a ligand or some kind of agent that can dissolve easily into the blood. How are you assured that is what it's going to do, and why like I say, why in our industry are we more concerned with aversion, whereas in the medical industry, medicine.
Sure. I mean, happily, I'm a very long way away from anything going near a patient personally, so this is not me injecting anybody with things. So it's sort of exactly what Tom was just saying previously, that different sorts of decay can be used for different things. So if you're thinking about the use for therapy, then the beta emitters, the range of damage within the tissue is longer. So they have a lower linear energy transfer than the alpha emitters. So if you're wanting to limit the sort of collateral damage to the healthy tissues, then this is one of the reasons why alpha emitters can be useful. So you want the shorter range, and also you want the highly damaging radiation exactly where you want it. So you want to be getting sort of the double strand breaks in the DNA. You want to be making sure the cancerous tissue is really dead. Again, this is not directly my field. I'm really focused on the production of exotic nuclei, but in terms of when it is injected into a patient, if it's a radiometal, it's sort of held by a chelator. So this is something that holds on to the isotope itself, and then this is joined to a well-designed molecule that will get the radioisotope to the part of the body that is of interest. So that is something that is obviously very carefully designed. It involves sort of chemistry and biology. There are other options as well. So there's something called brachytherapy. This is where sort of sealed sources are put inside a patient. This is also radioisotopes. It's typically beta emitters that are used there because the radiation has to make it through the capsule. So in those cases, you're not relying on the body's natural processes. This is something that would be put in place by the clinical team. Initially, that was sort of alpha emitters, but it's moved on to beta emitters. But the main reason why alpha emitters are sort of so exciting in that respect is that it's really highly effective and short range radiation, and it's also useful to use the body's natural processes. So, in the unfortunate case where cancers have spread, then they can, as long as they are sufficiently targeted that they will go to the cancerous tissue, it can be affecting all of the cancers throughout the body, not just in a certain region of the body. And this is where, if it was sort of proton beam therapy or something like that, it would be a real challenge to try to hit all of those tumors.
Okay, thank you. I want to ask you both a bit more about your backgrounds and particularly your relevant research fields. So obviously I mentioned TRIUMPH and CERN, and I also want to come on to the reactor versus accelerator production side of things. So maybe start with you, and you could talk a bit about that.
Sure. Yes, absolutely. So I worked for some time at CERN and TRIUMPH, which is Canada's National Particle Accelerator Centre. And this was more fundamental physics based, so it was producing exotic nuclei for fundamental physics. And then the majority of the work that I'm doing now is sort of looking at how much we can use that technology to produce medically relevant or industrially relevant isotopes. I've not completely left that field. There is still some fundamental physics, but it's also useful for cross-pollination and getting beam time in those sorts of labs. So right now, we're setting up some lab space at the university, at the Photon Science Institute. It's going to be doing a number of things, but for my work specifically, it's ion source development, and also sort of the development of what we'd call a hot offline separator. So the standard approach is, whether it is in a reactor, or whether it's accelerator based or all sorts of alternatives, you can get some co-produced isotopes in the reaction processes. So it's not always clean. We have chemical methods if it's elemental impurities, so impurities from different elements, but it's obviously a challenge. You can't separate chemically if it's isotopic impurities. So if there are other isotopes of the same element that are produced. So that's where the techniques that are used at CERN and at Triumph in the nuclear facilities there come in. So you can have electromagnetic isotope separators, so they separate out by mass, essentially, and it's very well it works well in collaboration, I guess, with the chemical separation. There's debate about the extent to which it's directly useful for sort of large-scale production, so when it's really treating populations. But it's a really excellent way of having an adaptable process. So for producing small amounts of radioisotopes that could then be used in clinical studies, that this seems to be a useful and adaptable way forward.
That leads us nicely on, because obviously a lot of these isotopes are produced in very small quantities and they're not really needed in large amounts necessarily, or at least even if they are, they're not across time, they're needed at different points in time. So, and given the short half-life of a lot of them, you need to produce them on demand. So I would like to go back to Tom of Astral Systems and ask you a bit about your company and maybe how your company is meeting that demand, as it were, for short life, low production scale, very specific specialized isotopes.
Sure, yeah. So at Astral, we produce compact fusion devices. Unlike just about every other fusion company, we're not going after energy production. We recognize that fusion has other utilities in the way that kind of nuclear in general isn't just used for kind of one purpose. So yeah, we use our systems to fusion takes place via inertial electrostatic confinement fusion. We use the neutrons produced in that to produce medical isotopes. So we're using them as just a neutron source, effectively. The difference compared to, say, the most common neutron sources for isotope production are research reactors, but these tend to be lower energy neutrons, more in the kind of thermal range. But the deuterium, and deuterium-tritium fusion reactions that take place in our systems, they produce neutrons at energies of 2.45 or 14.1 MeV, much higher than those in kind of typical research reactors. And what this means is that with higher energy neutrons, it unlocks a wider variety of different nuclear reactions that you can access. But as Thomas said, that what that does mean is you tend to get sometimes a broader set of reactions, so you can get more impurities, but there's a kind of a fine balance of managing that using enriched target material or carefully selecting your target design, basically.
Okay. So with your company, are you involved as a company? Is it more the physics technological side of things, or do you say concern yourself with supply chain or like the wider implications, as it were?
Yeah, absolutely. So we're British-based company. We're based down in Bristol. The supply of isotopes in the UK is terrible, to be honest. We import over 80% of our isotopes used in nuclear medicine. Really, the only isotope that is produced commonly in the UK is fluorine-18. All of our technetium is imported, all our iodine-131 is imported. We have very kind of poor supply chains. So one of our goals is to hopefully change that and have domestic supply of isotopes. Our technology can't produce all isotopes. There's no technology that can produce all isotopes that, well, potentially very high energy.
Can't produce all isotopes cost effectively.
Yeah.
I guess, sorry.
Yeah.
But yeah, so it's about having different technologies available to produce a wide variety of isotopes. And as we were saying earlier, it's important to have that selection, that option of different isotopes available.
Okay. Can we categorize isotopes into these energy bands, for example? Like, can you give us examples of what you produce versus what it can't produce?
So our dominating reactions that we're able to access from the kind of fast neutrons that we have are N2N, N3N, and NP. So that, if you kind of picture the chart of the nuclides, if you start with a stable isotope, you can kind of move over to the left as such. Whereas accelerators, so protons, cyclotrons would typically be PN reactions, so they kind of move the other direction, very, very broadly speaking. Okay. But what this means is that our technology is more suited to the production of therapeutic isotopes, as in beta emitters rather than positron emitters.
Okay, thank you. Let's go from there. So we've mentioned accelerators and reactors, Tom. Maybe you can give us more of an idea of. So we've talked about neutron. Have we talked about neutrons or like versus proton acceleration?
Sure, I can say a little bit. Yeah. So the as Tom was saying, the different regions of the nuclear chart, they can be sort of populated well by different technologies, and that's sort of one of the interesting things at the moment about the current times. Mm-hmm. So if it is the case, or it does seem to be the case, that a lot of the research reactors are aging, and also whether it's accelerator-based productions or other options are being explored, then to some extent it widens the available region of potential radioisotopes that could be employed, or different technologies that could potentially replace the research reactors. As Tom was saying, so the isol techniques with higher energy protons, so sort of in the hundreds to the thousands of MeV, these are sort of big, expensive systems. Yeah. These are well used at the moment for fundamental physics, so they can cover the full nuclear chart one way or another. Mm-hmm. But so these are great places to go again for sort of setting up clinical trials, I guess. Yeah. So for getting small scale amounts, but
expensive systems.
Yes. Yeah. So there may be, or will likely be, more efficient ways going into mass production than somewhere else.
So, with regards to cost, then, is there any other ways Astral is meeting the demand for the supply chain, like in terms of cost, or are these things really expensive still to produce, even with your technology?
No, I mean our technology itself is relatively cheap in terms of compared to a cyclotron, much cheaper, way cheaper than a research reactor, that's for sure. So our technology is kind of small modular based, so it's designed to be easy to kind of have multiple systems to kind of increase the neutron flux, basically. Mm-hmm. And so also one of the things that we're looking at is looking at existing isotopes, so copper-64, for example, which is a diagnostic isotope, can be used for therapy as well, actually. But it's typically produced on a cyclotron, proton on a proton beam, but it starts from a nickel-64 target, which I think nickel-64 is something about 0.4% abundant, in less than 1%, very, very low abundance. So very, very expensive to access that target material. Whereas our technology, we start from zinc-64, which is over 50% abundant, or almost 50% abundant, and actually kind of a byproduct from the civil nuclear industry. So using different routes to existing isotopes is a way, because the target material can be a kind of a large cost of that of the production process.
Okay. So can the target material vary to some degree then? I mean, my impression was, if you want an isotope, you need a target material, but there are other ways to like say, to bring down the cost with that.
Yeah, so I mean, there's different nuclear reactions that can get to the same product, so you can go different ways on the chart of the isotopes, basically.
And it's interesting, this transition from the physics, that maybe you've got the research side, to the supply chain, to the biology and the chemistry. I mean, you must be familiar with the chemical separation. It sounds like it even might play a role in your research, but personally, or
no, from my side, no. It really is mass separation. So we ionize the species, and then we use electric and magnetic fields to sort of guide and then separate out the different masses, so as they pass through a separator magnet.
Yeah.
But I guess the the point is the reason why it has a role in certain cases is that sort of chemical separation has its limits, I guess is the point.
Yeah.
So if your impurities are of the same element, then chemically they're going to behave in the same way.
Okay. Should we say a few words about theranostics? I think that's a word anyone's heard in this room necessarily, so it would be interesting to introduce the concept.
Sure, I can say something briefly, and then maybe Tom, you want to say something. So, yeah, theranostics. Well, some people put a G in the middle of it, depending on how good your Greek is. But I think theranostics is the standard way of saying it now. From what I understand, a sort of key thing is understanding where the dose is being delivered and the actual amount of dose that's being delivered to the right part in the patient. So there's always a balance to be struck for clinical teams. They want to make sure they've killed off the cancerous tissues while obviously limiting the damage to the patient. So there's a balance to be struck about how much of a certain medicine is provided. The advantage of theranostics is that you can use the same delivery mechanism. So when we were talking before that you have your radioisotope and then it's bound in some way to a molecule that will accumulate in the target region. So if you have isotopes of the same element, the delivery mechanism it will behave in the same way depending on if you're using the isotope of that element that works for diagnostics, that will show where the delivery mechanism is taking the radioactive isotopes, or whether you've attached the isotope that's useful for therapy. So in this way, you have the clinicians have a much better handle of both the dose that is being delivered and the location where it's being delivered to. So otherwise, I mean, there are theranostic approaches where there are pairs of isotopes of different elements, but it works much better when they are the same element, and you can really have exactly the same radiopharmaceutical just with the radioisotope swapped out. So terbium is a sort of good classic example of this. You can have terbium isotopes that can be used for PET or SPECT, and then also for beta therapy, alpha therapy, or Auger therapy as well. So within that, there are that's the direction that some people are moving towards.
Okay. Would you like to say a few words as well?
I don't think.
Okay.
Yeah.
I want to just clarify. You said ISOL earlier and SPECTs now. I just wanted to clarify some acronyms just in case we get questions later.
So ISOL is isotope separation online. This is something that was developed in the 60s and earlier, in fact. So the idea was that you can, if you're producing your radioisotopes, if you couple the production target to a mass separator, then in this way you can really get the shorter-lived species. So you're not having it in a batch mode or a separated system where you have to produce the isotopes and then they're transported to the separation mechanism. In this way, there's a sort of simultaneous production and separation.
Okay.
So that's where ISOL comes in. So that's the production at the Isolde facility at CERN. So CERN isn't just the LHC. There's sort of nuclear physics and all sorts of other things going on there. So the oldest ongoing experiment at CERN is Isolde, and this is the nuclear physics facility which is based on that. So they use 1.2 GeV moving up to 2 GeV in the future, protons, to produce these species. And then for the other acronym, I guess it was SPECT. So this is where it's a diagnostic technique. You want an isotope with a single photon. So it's that's where the metastable state of technetium-99 comes in. So when it decays to its ground state, it releases a 141 keV photon. And because it's a single photon, it's a lot easier to sort of track where it's come from. There's less of a worry in terms of your system and differentiating between different photon peaks. And then PET uses 2 back-to-back photons that come from the annihilation of the positron. So that's a positron emitter, but then you're detecting the back-to-back 511 keV photons.
It's almost like a triangulation, I suppose, of events in the body, so you can actually get a spatial component to where those events
For
happen.
both of them, yes. So they often combine it with CT scans, so X-rays essentially. So the PET and the SPECT, they're very good at tracking biological processes. And then if you overlay it with the CT scan, which gives you the anatomic picture inside, then you can see where the biological process is taking place.
Okay, excellent stuff. Yeah, you mentioned terbium as well. I was reading how I think you derive 4 separate. Is it a precursor terbium, or is it itself used, and then also it can be also used to derive other isotopes? Is it what's its makeup?
The terbium isotopes would typically be the ones that you would then be. They would be the therapeutic or the diagnostic isotopes used. Okay. As Tom was saying, you can get to these isotopes via different routes. So your target material would likely change both on depending on which terbium isotope you're interested in, but also what your irradiation setup is like. Okay. We were producing some dysprosium actually that was then decaying into the terbium for some clinical trials at Isolde at CERN. So yeah, there are various routes. It really depends on what you want.
It sounds very convoluted in that respect. I wanted to ask you as well about, I mean, obviously you're very much in the research side of things, but you're talking about Isolde, which sounds like it's used for medical isotope production. So it's not just, it's at CERN, which you consider to be like a research institute, but it has a very industry-facing role, would you say?
So they have, it's a fundamental physics facility, and it's the same as they have the ISAC facility at Triumph. So that does very similar stuff. So Isolde works with sort of GeV level photons. ISAC works with 500 MeV photons, but the system is essentially the same. So you're irradiating a target, extracting the nuclides. But yeah, the range of physics and other science that happens there is sort of a really big variety. So there's biology experiments, solid-state physics experiments. Some stuff does come with industry as well. CERN has also built the Medisys facility, which is next to Isolde, and this irradiates targets at Isolde, and then they come along a rabbit line, and then they use that for mass separation there of species. So that is largely medical-related isotope production as well.
Very good, thank you. And you also mentioned technetium-99, which sounds like a bit of a workhorse. It sounds like it's, would you say it's one of the more commonly in terms of volume?
Certainly. And what Tom was saying earlier, it's not just that we import sort of 80% of our medical isotopes. As Tom was saying, we import 100% of certain key isotopes, and that really puts us at a challenge. So that was where, as research reactors are aging and being shut down, this is when there's sort of supply issues for technetium-99m. And this is where then suddenly it's a challenge for hospitals to do SPECT scans. And it's again, it's just by their nature, we obviously can't stockpile them, right? So by the short-lived nature, it's something that either we produce or we have to have secure supply chains one way or another.
Could there be a risk of a scenario where, I mean, at least for the UK locally, where these isotopes just can't be supplied?
It happens regularly. I mean, maybe Tom can talk a bit more about that, but yeah.
Please do.
Yeah, I mean, that happened most recently. I think it was in October 2024. The BR2 reactor in Belgium went down for unexpected maintenance, and there was massive shortages of many isotopes. So there's, I think, around 80 research reactors in the world that produce medical isotopes. However, 80% of those isotopes come from just 6 reactors in the world. Many of these were built in the 60s and are already well past their kind of decommissioning plan, but they've kind of kept them running. There are a couple of new reactors being built at the moment that will be coming online, but they're very behind schedule. So there's the PET and Reactor in the Netherlands, and then there's one in France as well. But one thing that is quite interesting, so recently the CANDU reactors in Canada, so run by Bruce Power and OPG, have started producing isotopes on their power reactors, which is a world first. And I'm not aware of any other kind of reactor design that would be able to do this, just due to their kind of continuous refueling nature. And I'm not a reactor physicist, but they're quite unique in their kind of ability to do this. And what's very interesting is the quantity of isotopes that they can make in these. I mean, they've got, between the Bruce Power site and the APG site, I think they've got 16 CANDU reactors, and they've only currently got 2 target delivery systems, but they could scale it up enormously. So it'll be interesting to see what happens if they can kind of fill the space that some of these older reactors when they shut down. But I think it's the scale of their process would only ever be suited for isotopes in very, very large demand. So they wouldn't be looking at research level isotopes because it just wouldn't be worth it. The safety cases involved and the kind of the investment needed to kind of develop these isotopes. So maybe that will free up more space in the research reactors that can do more of this. So we'll see.
Yeah, it strikes me that with the reactors for producing power, I'm not sure if the CANDU conforms to this given its natural enrichment levels, but we talk in this country, you know, we've had reprocessing in the past, but you very much get a cocktail. You know, you get more or less the entire periodic table in a nice slurry, and it's like, well, it's in there somewhere, you know, pick it out if you like, but also it's that very much, it sounds like you've got this kind of clean approach to, like with these cyclotrons where you produce isotopes very specifically, whereas the nuclear side of things in the industry, like energy production, it's much harder to make it, like say, a safety case, or even just to get crosstalk and see productive, I guess, use of those isotopes.
Yeah, I think particularly in the CANDU case, it took a long time to. I mean, if you think about it from the kind of the company's perspective, it's a tiny market compared to the energy market, really, and it took a lot of convincing them to put that investment in, and I wouldn't say it's at risk of the kind of the reactor's operation, but it's going to have a perturbation on it, definitely.
For sure. It sounds like was the government involved in any capacity, or is this very much a kind of venture, like say private enterprise, for example, Astral Systems, probably in a similar situation where its investment is required, assurance, risk to be measured?
Good question. I don't actually know in Canada. I know they have a very good kind of ecosystem, and there's a lot of kind of cross collaboration between companies in Canada, probably much better than we have in the UK. But yeah, I'm not sure the details of that kind of decision. But I mean, the CANDU reactors have been so cobalt-60, which is used for kind of gamma knives, gamma knives and external beam therapy. So that's been produced in the CANDU reactors for a long time. But in a different approach, they put that in with the fuel and kind of leave it in there for 2 years. So you get very, very high specific activity cobalt-60, but it takes a long time to make. Yeah.
Okay. Good. Would you like to ask?
Well, I mean, just very quickly, I guess to sort of reinforce the point that there is the difference between the research reactors and the reactors for producing energy. It's a specific case it's very impressive that they've been able to do that here. But when we say that there are no research reactors in the UK currently, it's not that the new nuclear power stations that are being built could sort of be used for that as well. They're specifically built for producing power, not for producing radioisotopes. I think it's NNL. There are some. There's certainly some significant interest in trying to extract medically relevant isotopes from nuclear waste. So I think lead-212 is on there as a potential candidate. So yeah, there is interest, but it's certainly a challenge.
Yeah, and it's something that's sort of dwindled the interest. Obviously, Thorpe shut down at Sellafield, so you're not even seeing any form of separation happening at the moment. So yeah,
I think it's something that they are attempting to push. So I've seen a few different talks over the last couple of years.
Seems like I wouldn't say low-hanging fruit, but it's certainly like a UK-centric viable option, I would say. I did want to ask you both. I think we've established the UK supply chain is slightly lacking, but is there any? You mentioned we produce roughly 20% of our isotopes. So.
I think so. I guess the point to consider is it's very isotope dependent. So for the PET isotopes, for example, a lot of those are produced in-house in the sort of ground floor, below floor basements of hospitals with small accelerators there. There's some rubidium isotopes that are produced in Birmingham at the cyclotron that they have there. I don't know, Tom, if you want to say more about the UK supply chain, but it's quite specific.
Yeah, you mentioned the Birmingham one. I think that's quite a big deal in the research world? Is there anything like that we have otherwise, or is Birmingham quite the flagship in that respect?
I think so. From my understanding, a lot of it comes down to the current and the energy. So the typical medical cyclotrons are sort of, I think, 16 MeV or below, and the Birmingham cyclotron goes up to something like 40 MeV. So it gives a broader range of options available, and they're looking at options for renewing this in the future. So a new cyclotron facility, I think, is on the cards if they can get the funding for it.
We spoke previously about Bangor, and you mentioned the project there.
Yeah, that's true. So I'm not involved in it. I'm not at all an expert on this. So there's the Project Arthur idea. So this is developing a research reactor or building a research reactor in North Wales. I'm not sure if the new modular reactors sort of being built in Anglesey means that there's a limitation on what can be built at the same time there, in the same sort of region of the country. But yeah, that was the idea. Their idea was to take a proven reactor design that's sort of built in Australia, and then build it in the UK as a sort of a way of having sovereign supply, which is certainly worth exploring.
It does sound like a lot of this comes down to cost. So I'd like to ask you both sort of, where could you see a finite pot of money being best spent? What kind of like cyclotrons? It sounds like hospitals seem to have their own to a large extent. I mean, we're quite near the Christie, aren't we? So I think that's one of the larger hospitals in Europe concerning.
Yes, yeah. And again, I don't work at the Christie, but yeah, I understand that it is. There's certainly a lot of research related to medical isotopes and cancer treatments that goes on there. Yeah, I don't know. It depends how big the pot of money was, I suppose. Because I should highlight that nuclear physics is currently being defunded in the UK. So avoiding the defunding of nuclear physics would be useful in terms of limiting the sort of the high throughput of sort of qualified personnel to work on these sorts of systems. I think accelerator sort of capabilities and facilities are very useful for this sort of small scale production. If money is available for something like a larger accelerator or some sort of research reactor, then an awful lot could be done there. But I mean, obviously there are exciting new technologies that maybe I want to highlight.
Yeah, no, thank you. I think for me, I was just at a meeting this morning actually about the kind of concept of building a nuclear medicine supercluster, which is actually planned. They're planning it near Manchester Airport, which I think that would be really, because in the UK we have almost all of the component parts. We've got the research, we've got the hospitals, we've got lots of very well-trained people. We just don't have some of the kind of basic infrastructure, basically. So we do have the one high-energy cyclotron in Birmingham. That's, I think, over 50 years old now, and it was second-hand when it arrived as well. Whereas, so if you look at Japan, for example, they really heavily invested in lots of medium energy, which is still higher than the kind of 16 MeV, but cyclotron, so they can produce astatine 211, for example, which has been made in Birmingham, but not frequently, not routinely. Which is astatine 211 is another alpha emitter. So, I mean, a research reactor would be great. They're so expensive, though. I mean, you're looking at 500 million really to build a research reactor, and they take a long time to build. Personally, I think investment in accelerator technology, a few high energy cyclotrons in the UK and other technology, fusion technology, or photon accelerators, for example. I think we could do a lot with that, and it would be more flexible, much faster to build, and less sole use.
It sounds like a similar story in the nuclear industry. I mean, obviously there's this renaissance we talk about, but it sounds like nuclear isn't just energy production or bombs. It's it's the medical. There's so many different flavors, and maybe as part of that policy of expansion, it sounds like the accelerators would be small pickings, and they're like small fry, I suppose, in terms of the financing, and compared to like some of the more larger projects. So yeah, it seems like something that should be kept up. And I guess as a UK, as a player internationally as well, you know, imagine if we not only produced our own isotopes but could export them to other people, you know,
Yeah,
reclaim
no,
our name.
exactly. Yeah, there's a huge export market there for sure. And I mean, depending on I mean, actinium-225, for example, it's got a half-life of 10 days. You can get that anywhere in the world quite easily. So there's some very short half-life things that you do have to really produce quite locally. But a lot of the isotopes that are kind of being used commonly at the moment, really, you can ship them at a decent distance.
Can either of you shed light on the logistics of, like, are they flown in and then taken to a local airport and then in like a secure van? Like, how do you know much about that sort of thing?
Yeah, they're typically flown. So East Midlands Airport is the only airport, I believe, in the UK which is licensed to fly radioactive material, which does make it slightly more complicated. I think some from Europe, so we get some, say, zirconium from Amsterdam, for example. I think that comes through the kind of Channel Tunnel.
Okay.
But yeah, typically flown. So it's quite interesting, actually. So that in the US, there's a big kind of nuclear medicine hub that kind of popped up around Indianapolis, which is a bit of a kind of unusual place for it to kind of develop. And if you talk to people, one of the main reasons it happened there is because it's next to a FedEx depot. It's one of the main FedEx depots in the US. So it's just, rather than because each connecting flight an isotope or nuclear medicine has to go on increases the risk of it being delayed or not making it. So yeah, being next to the depot was one of the kind of driving factors in that happening in Indianapolis.
Thank you. Very good. I'm aware of time, and I did want to open up to Q&A. So, do any of you have any final remarks before we move to Q&A, or are you happy just to dive right
happy
in?
to answer any questions.
I feel like this is a very broad and also specialised topic in a lot of ways, so it feels quite intimidating. At least I feel intimidated. The number of questions, but we can shoot for questions. So we need to have a bit of a situation. So we're going to have one mic at the front, one mic going round. So we've only got two mics, I'm afraid. Obviously, for the people online, we need to speak into the mics so they can hear us. So, yeah, if Farouk's okay to take my mic, and then we'll field questions to the panel. Thank you.
Thank you. I've understood that there's a focus on production of isotopes for use and on research. So I've got a question in each area, actually. Focusing on the production, you mentioned that UK needs to import 100% of the key isotopes. So I wondered if you could just characterise what you think those key isotopes are, and by implication, if we were to have our own facility, which isotope productions we should prioritise. So
the workhorse isotope is technetium-99m, which is produced from molybdenum-99 generators. That's responsible for, I think, 80% of nuclear medicine procedures in the UK and around the world. So that's all imported. Iodine-131 is used a lot in thyroid cancer and hypothyroidism. That's imported. Lutetium-177, which is the kind of quite new, very popular. So it's Lutathera is the approved product in the UK. There's also Pluvicto, which is approved elsewhere in the world. So Lutathera is a neuroendocrine tumor drug, and then Pluvicto is prostate cancer. So that's all imported. So those three isotopes would be a huge chunk of what we currently are importing. Okay, thank you. Well, the other half of the question, it probably is for you. I think you said you've got a Future Leaders Fellowship. So, nice, easy question. What are the key research challenges in radioisotopes?
Oh, wow. So the goal, at least of my fellowship, was to try to make small-scale production easier. So this is sort of very early on in the process. This is to try and make to try and improve sort of researchers' access to sort of novel medical isotopes for then sort of future treatments and options. And part of the reason for this is the changing landscape as research reactors are shutting down and potentially alternative isotopes might be considered. So just availability of some of these currently novel isotopes is a real challenge. So I'm not saying it's a comparable challenge to the fact that the UK maybe needs a sovereign supply of some of the existing ones, but it is a smaller or other challenge that it is there and that I think should be addressed. So currently for my fellowship, the idea is to work on what we'd call it like a hot offline separator system. So this would accept isotopes that are irradiated elsewhere, but then provide the mass separation capabilities. So this is something that has been demonstrated to be useful and desired at CERN, actually. So CERN goes through these periodic long shutdowns. They're currently going through a long shutdown at the moment, so there are no protons. But the Medicis facility, which is a hot offline separator, so it accepts pre-irradiated targets and then is used for separation. This is going to be well used, from what I understand, during their shutdown. So that's sort of the small part that my fellowship is hoping to deliver in that field.
And any sort of key research topics that aren't within your fellowship, but nevertheless you recognise as state of the art and things that we should be working on or are working on?
I think so. It's very much driven by demand to some extent. So at the moment, there's, I suppose, you could see it as two priorities. So one is a reasonable supply of the existing isotopes that are currently in use. These are still going to be workhorses long into the future, and finding a sovereign supply of those. And then it's the alpha emitters that are currently sort of very popular at the moment in terms of what may be used in the future. So whether it is astatine 211, whether it is actinium-225 or terbium-149, so a viable local way of producing these isotopes within the UK, I think that would have a significant effect.
All right, okay. We've got a question from the online platform, and it's by Miguel. Does the UK contribute to the construction of these new reactors for the isotope production? And does it consider the construction of new national reactors to increase the security of supply of such isotopes, to prevent cases such as like the one mentioned by the Belgium outage?
From what I'm aware, I don't think the UK has contributed to the building of these reactors. Not 100% sure on that, but I don't think so. Interestingly, so there was, going back quite a while now, but there was like very serious shortages of molybdenum and technetium back in the kind of mid 2000s, late 2000s, and the US government after that made isotope supply a kind of a national security issue, basically. So it really kind of escalated the importance of it, which means they put a lot more funding into it. The UK doesn't have that same kind of categorization. It's not. I'm just trying to find a government department that even takes responsibility for isotope supply is a challenge. So yeah, there isn't really that kind of government level oversight to it at all.
Okay.
Thanks, guys. My question is about the mod delivery system, so maybe slightly outside your wheelhouses, but are you working with a particular delivery system in mind when you're generating your more kind of hard to access isotopes? And I just wonder how the delivery system and the making of the ligands and the chelators is that research is also happening in the UK, maybe slightly beyond your remit, but do you interface with that kind of research?
Yeah, no, absolutely. That's really important. So if you look at PET isotopes, so fluorine-18, carbon-11, they tended to be more small molecule. So the actual isotope itself could have a significant effect on the kind of the distribution in the body. So the most common PET PET tracer is FDG, which is a fluorinated glucose derivative. So you can't just put a big kind of radiometal on the side of that. It will totally change how it behaves in the body. A lot of the kind of current therapeutics and a lot of those that are in clinical trials are more peptide based or kind of antibody based or kind of antibody fragment based. So the isotope has less of an effect on the kind of distribution in the body, just because it's a much smaller part of the whole molecule. But yeah, there's a huge amount of work going into that, and it's not just the targeting part. There's also the chelator. So what actually holds the isotope. There's no kind of one perfect chelator that works for all different radiometals. So yeah, there's a lot of development work going on kind of there as well. So yeah, there's a lot of factors to consider, but it's one thing I kind of touched on earlier is it's quite important that you match the half-life of the isotope to the biological half-life of your molecule. So if you have a molecule that goes in, binds, clears very quickly within kind of a couple of hours, you don't want to use an isotope with a kind of a 10-day half-life, because it won't decay where you want it to. It will be excreted and then decay. So there's a lot of things that you need to kind of match up, basically.
Hi. Yeah, this whole nuclear renaissance thing at the minute, and HALEU and advanced reactors are the buzzwords of the day. And I keep seeing medical isotopes as a byproduct of these advanced reactors. But just picking up on something you said there, Tom, but like, NNL worked with Japan to develop a UK high temperature gas reactor, research reactor that they were going to build, and DESNZ, I believe, have pulled the funding for that. So where does the responsibility sit for security of medical isotopes, and sort of where's the delineation between research institutions and sovereign supply, because it seems like a bit of a blind spot at the minute.
Yeah, no, very good question. So it used to sit with DESNZ. They've basically said it's not our responsibility. So I think it's now moved over to the Department of Health. However, it's not clear who in the Department of Health is actually responsible ultimately. So if you look at the countries that have had really successful isotope supply kind of systems in place, they have a specific person, a minister in government whose responsibility is kind of looking after this. And the UK doesn't have that, which I think is one of the issues, basically.
A question for Tom, but also, well, we're called Tom. So you touched on Astral Systems developing fusion devices which are not focused for energy. You're more looking at isotopic production and that sort of thing. Could you tell us more about these fusion devices? What does the ideal fusion device for isotopic production look like?
Sure. So it's all about flux, really. You want as the highest kind of density of neutrons possible, because if you're particularly short-lived isotopes, you want to transmute as many of that target material into your product material as quickly as possible. So our approach is making devices very small, so you can get your targets very close to the source of the neutron. So the further you go away from it, the kind of the lower that flux will be. If these kind of large kind of tokamak devices come online, the flux is going to be very, very high. But where do you fit a target into? I mean, the designs are so complicated. Like, where do you just? Yeah, I don't know. There's companies that are kind of talking about nuclear medicine isotope production, but I haven't seen any examples of having like a target station in them, basically. I mean, there's a lot of problems to solve before they get there.
Okay, so the target stations, are they pulled out on beam lines? Are they inside like the breeder blanket of the reactor? Like, where do you put them?
Yeah, so we I mean, our systems aren't kind of tokamak based. But so we literally have them right. So our systems are kind of they're quite small, 1.3 meters high, 13 centimeters diameter. They're cylinders, and we literally surround our systems with target material on the outside.
Okay, it's more like a linac, it's sort of cylinder shape.
Think of it as like a strip light bulb almost. So
Okay.
it's an isotropic, because with protons with charged particles, you can direct them into a beam. You can't do that with neutrons, really. So they come out in all directions, which is more of a challenge. So yeah, we just try and kind of capture as many of those neutrons as possible. So we do use larger targets than you would in a cyclotron typically.
Just to say, so for some of the newer ISOL facilities, or somewhere they're being upgraded, then target extraction of sort of symbiotic or parasitic targets is something that's considered. So putting targets in beam dumps, for example, and then having a rabbit line for extraction. This is something that is being developed at Triumph at the moment. So this would be sort of targets of the size of a bottle of water, perhaps. So yeah, it's something that I think both with reactors and with other systems, when you find areas where there's a significant proton flux or a significant photon flux or neutron flux, then it is becoming more of interest, or something that people are perhaps thinking about a bit more. But yeah, at least for the ISOL systems, it's again still a lot of the time perhaps smaller scale production compared to if you could make it work for some sort of nuclear reactor.
My other one's run away. Thanks so much. Yeah, that just about brings us to the full hour. So thank you for coming. I want to thank our speakers as well for taking the time. Obviously, I hope you've learned something, you know, and widened your field of awareness. But yeah, if you have any more questions, I'm sure our speakers are happy to talk at the end. So yeah, thank you all for coming, and round of applause, please, for our speakers. Thanks so much.